What is rehab or rehabilitation? My name is Fred Bagares, a board-certified sports and spine medicine physician in Virginia Beach, Virginia. After 10 years of practice, I still find musculoskeletal medicine both fascinating and challenging. This podcast is about the lingering thoughts and questions I've had after residency and fellowship. My hope is to spark discussion, challenge dogma, and share my experiences in musculoskeletal medicine. Welcome to the Talking Rehab podcast. There are two key questions that I often think about. Number one is, how do we attribute pain to certain structures, or how do we explain where pain comes from? But also, whether pain is always caused by what we find on imaging. This is something I've thought about a lot over the years. The more I practice, the more I realize that the connection between pain and pathology isn't as straightforward as we like to think. And yet, time and time again, I see patients being told that their pain must be coming from what shows up on a scan. Arthritis, a meniscus tear, some version of a degenerative change. But does that really actually make sense? That's what I want to unpack today. Pathology can occur in two different ways. One is from a specific injury, like twisting your knee, coming down from a rebound, or slipping on ice. But you can also develop pathology gradually through general wear and tear. For the purposes of today's discussion, let's talk about the knee. Some of the most common findings we see on imaging include tendinopathy, ligament sprains and strains, meniscus tears, and also arthritis. Now, when someone is in their 20s and they develop knee pain, it's usually diagnosed as a contusion or something called patellofemoral syndrome. And that's assuming that physical examination is relatively unremarkable, meaning there's no significant laxity, but they just simply have pain. In that particular visit, they might get an X-ray, but as long as there is no evidence of structural injury, an MRI is not typically indicated. Plus, most of the time, the treatment is fairly simple. Education, over-the-counter medications, maybe some rest, and the pain will go away. But at a certain point, whether it's due to aging, increased physical activity, or just an unlucky fall, the decision-making is different with time and age. Most pain symptoms will resolve within 4 to 6 weeks, but when the pain sticks around longer than expected, the diagnosis process shifts. So let's compare and contrast this to the previous example where a 20-year-old slips and falls and develops knee pain. Now let's fast forward to your 40s or 50s. You slip and fall, you land on your knee, you go to the doctor, and then they take an X-ray. This time, in your 40s, you start to have mild arthritic changes. And as opposed to patellofemoral syndrome, all of a sudden the conclusion is, oh, your knee pain is from the arthritis. But let's take a step back. Imagine if that same person had fallen a day early before they had knee pain, and we took an X-ray then. Would the arthritis still be there? Yes, but they weren't in pain. So why do we suddenly attribute the pain to the arthritis just because it hurts now? Why don't we conclude that it's patellofemoral syndrome like is typically done when you're in your 20s? This is a crucial shift in thinking. Here's something to consider. The treatment for most knee conditions is often the same. When you're diagnosed with arthritis, patellofemoral syndrome, or even a simple contusion, the initial recommendations are usually over-the-counter medications, rest, and physical therapy. So if the treatment is the same, I don't think physicians are as motivated to give a specific diagnosis, because in the end, it typically doesn't make a difference. Most things improve with 4 to 6 weeks of conservative management. So why would we focus on labeling the actual cause? However, let's assume that all of a sudden the symptoms continue past this 4 to 6 week time period, so essentially longer than expected. At this point, a physician may order an MRI. Now, ideally, a physician is ordering an MRI with a clinical suspicion of a particular structural injury versus them just generally getting an MRI to see if something pops up, which is side note, is probably the worst way to order any type of imaging. But let's say you get an MRI, and this is where things start to get even trickier. If there's no real physical examination findings, no evidence of laxity, and you order an MRI in someone's 20s, it's very, very common for the MRI to look super normal. And again, we land on the diagnosis of a contusion or patellofemoral syndrome. Now, the same situation, persistent symptoms, and an X-ray shows some mild arthritis, but now you get an MRI. The MRI will definitely show the extent of underlying arthritis, but it may not always be very helpful because it's guaranteed to show something. In addition to the arthritis, you'll probably see some evidence of degenerative meniscus tearing, some evidence of tendonitis or tendinopathy, and all of these findings tend to occur naturally with time. The problem is that these findings don't necessarily cause pain. But once they're on a report, their narrative shifts. And again, in 40 plus years old, persistent symptoms, a physician will commonly conclude that, the symptoms must be coming from this meniscus tear, or now your arthritis is flared up. And again, that doesn't make sense to me because it's the same exact mechanism, but the only difference is what we see on the imaging. I've had this conversation with many colleagues, and I think there's a mental trap that physicians fall into. We have a bias, or we put a lot of weight into objective findings, X-rays, MRIs, CAT scans, and that's mainly because we're trained to identify structural problems. That being said, physical examination and imaging doesn't always tell the entire story. It's uncomfortable for us to have a patient in pain and not have a clear culprit on imaging. So when we see something, even if it's just age-related changes, we tend to anchor onto it. I've had a number of people with knee pain and normal MRIs, and they end up having something that is not typically diagnosed on an MRI. They can have a friction syndrome of the IT band. They can have a fat pad impingement, which doesn't always clearly show up on MRI. It does, but not in its earlier stages. Sometimes you'll also see nerve irritations or nerve entrapments contributing to pain syndromes, or in this case, the knee. So again, physicians have a tendency to anchor onto changes that we see on reports and on imaging. But here's the flaw in that thinking. If a patient had a meniscus tear for years without pain, why is it suddenly the cause of their pain now? If someone can have severe arthritis but no pain, why do we assume arthritis is causing pain in this patient versus another? The truth is not all pain is structural. So what factors influence why some people heal faster than others? And I get this comment of heal, and over time, it may not actually be healing. It might actually be, why is it that some people recover faster than others, even in their 40s or 50s? The short answer is that it's multifactorial. But the one thing that I find predicts people recovering faster than others is if they are generally very physically active people, they have good physical attributes, and they have kind of a movement mindset. Those folks tend to recover faster than others. Now, one of the factors that is hard to change is just degenerative changes. The more degenerative changes you have in your knee, higher likelihood that it's going to take longer for you to recover compared to if you had no degenerative changes or if you had less degenerative changes in the knee. And I don't really have a great explanation for that. That's just kind of what I notice in essentially any arthritic joint or any degenerative joint. It doesn't have to just be the knee. It could be the ankle, the shoulder, the elbow. A degenerative joint just does not recover as fast. On some level, I think we have to reassess how we diagnose pain as clinicians, physicians in particular. The biggest shift I've made in my practice is realizing that pain can exist with findings, but that doesn't necessarily mean that the pain is caused by those findings. So this is that classic correlation does not equal causation. And we see this all the time. Patients in their 80s with severe arthritis and no pain versus patients in their 20s with mild findings and having debilitating pain. The findings on imaging don't always predict who is going to have symptoms and who is going to have the most severe symptoms. So clearly pain is much more complex than what we see on a scan. Not to mention there are several other causes of pain that are not screened for. Again, the common things we look for are structural changes that are picked up on MRI, tears, arthritis changes, alignment issues. But at least in my differential of knee pain, I have a laundry list of things that can cause knee pain that I've seen under ultrasound that don't on MRI or X-ray. So clearly pain is much more complex than what we see on a scan. This is why I encourage physicians and patients to step back and reconsider. Are we chasing the wrong cause? Are we treating the image instead of treating the patient? Are we just trying to make connections because it's much easier for us to make sense of things versus being uncomfortable with saying we don't know what's causing it? I bring this up because I think it's time we challenge traditional thinking around pain and imaging. It's easy to latch onto a clear explanation. This part looks bad, therefore it must be the problem. But the body just simply doesn't work that way. Sometimes pain isn't a broken part. Sometimes it's how the system functions as a whole. Sometimes there are limitations on what imaging studies can see. So I'll leave you with this. Next time you hear someone say your pain is because of arthritis or it's that meniscus tear, ask yourself, is it really? Is it really that? Or could you have pain with an underlying meniscus tear and have them be two separate issues? I'd love to hear your thoughts. If you've had an experience where image findings didn't match your pain, let me know. Reach out, share your story, and let's keep this conversation going. Thanks again for listening, and I'll catch you in the next episode.